Hello, friends. Today we are going to discuss the case of Apan Chirag. So we have this 65-year-old male patient known case of chronic liver disease since 2018 with a history of decompensated liver disease and stable endovascular lines. He came with history of melena since 1 week and hematemesis since 1 day. Last admission was 3 months back with upper GI bleed, and the color Doppler examination of the portal vein, which was done 1 month back, was suggestive of the portal hypertension. So on arrival in ICU, the pulse was 121, blood pressure was 90 by 60, RR was 24, saturation was 88%, started on 2 liter of O2. On CVS examination, we found S1, S2 audible, RS, air entry was equal on both sides. Per abdomen, it was distended, and the CNS patient was drowsy with the GCS score of E2, V2, M5. So regarding initial resuscitation of this patient was intubated in view of active hematemesis, and then we have started him on the 1 liter of plasma-lite solution. Injection albumin was started. The Riles tube and the Foley catheterization was done. Invasive lines were inserted, including central line and arterial line. RT aspirate was continuous and it was bloody. So the Foley catheterization was done, which drained 200 ml of the urine. So all routine investigation were sent, including complete blood count, renal function test, liver function test, ABG and TEC was sent. USG abdomen was done, which showed ascitic fluid. So the ABG of the patient was taken on 2 liters of O2, which showed pH of 7.217. Then the PCO2 was 41, PO2 was 65, bicarb was 16, lactate was 8.5, and HB was 4. So the ABG was showed the metabolic acidosis with lactic acidosis. The ECG and chest X-ray was taken. ECG showed sinus rhythm, chest X-ray was also normal. Then the 2D echo findings was ejection fraction was 40%. There was no regional wall motion abnormality. Grade 1 diastolic dysfunction, IVC could not appreciated because of abdominal distension. Then regarding by that time the blood investigation came, which showed HbO 4.3, WBC 17,000, platelet count 1,000 to 1,23,000. Creat was 1.64 and the BUN was 37. Sodium 133, potassium was a bit high 6. INR was 2.77, bilirubin was 2.2, SGOT 206, SGPT 152, ALP 70. This was the chest X-ray of this patient, which was taken after intubation. So far issues with this patient was hypotension, then this grade 3 hypovolemic hemorrhagic shock, and the metabolic acidosis. So the provisional diagnosis was hypovolemic hemorrhagic shock, severe upper GI bleed, decompensated liver disease in case of chronic liver disease with portal hypertension. So to calculate the severity of the bleeding, we have calculated this Blatchford score, which came out to be 18. The Rockall score for this patient is 8, and M65 score was 3. So we have so we have counseled the relatives regarding the high mortality and the risk of rebleeding. So meanwhile, we have transfused the patient with 10 point PRBC, 10 point cryoprecipitate. Patient was hypotensive, so we started him on inotropic support in view of hypotension. Started on the NORAD at 12 ml per hour due to requirement. Vasopressin was added at 2.4 ml per hour. So, yeah, gastro contact differentiate and they did bedside endoscopy, which showed active bleeding. Endovascular ligation was done, and after endovascular ligation, the patient's blood pressure was stabilized and NORAD requirement started reducing. So this was the gastroscopy report, which showed active bleeding varices, the endovascular ligation done with 3 band, and then patient was planned for triphasic CT. So this was the triphasic CT abdomen of this patient, which showed narrowing of the portal vein, thrombosis in the splenic vein, portal vein, and mesenteric vein. And then the plan was to go for tips versus bar. So again, the patient became hypotensive, inotropic support started increasing, patient's urine output was dropping, and patient was passing only 10 to 20 ml per hour. The nephrology reference was given, and the patient possible need of RRT was explained to relative. So this was this investigation. So patient was sedated. Investigation on day two. HB was 5.9, PCV was 20, WBC 13,000, platelet count 85,000, creat was 5.86. Blood urea nitrogen 69, sodium 132, potassium 4.5, INR was 1.3, and then SGOT 556, SGOT 316, bilirubin 2.3. So patient was sedated on mechanical ventilation with PRVC, and the still patient was hypotensive with NORAD requirement of 15 ml per hour and vasopressin requirement of 2.4 ml per hour. So issues with this patient was anemia, thrombocytopenia, AKI stage 3, and hypovolemic shock. And the diagnosis of this patient was upper GI bleed, total hypertension, acute kidney injury, and hypovolemic shock. So relatives were counseled regarding need of RRT and critical prognosis. The relatives were not willing for any kind of aggressive management, and they have decided to go for supportive care. So patient became persistently hypotensive despite anesthetic support, bradycardia followed by asystole. CPR initiated as per ACLS protocol. Despite resuscitation, patient could not be revived, declared as dead. Now we will have brief discussion about upper GI. So, what is upper GI? So, bleeding from the source proximal to the ligament of treats is defined as upper GI bleed, and it can be defined as variceal or non-variceal bleed. So, variceal hemorrhage is the complication of end-stage liver disease, and non-variceal bleed can be due to peptic ulcer disease and various other causes. So causes of upper GI bleeding, variceal upper GI bleeding so causes could be variceal upper GI bleed, peptic ulcer bleed, Mallory West tear, angiodysplasia, Duflois lesion, colonic diverticular bleeding, and aortoenteric fistula. So for assessment, we need to take complete medical history, physical examination, nasogastric lavage. Then lab assessment should be done when the patient is present in ER. The high risk patient should be identified and timely intervention is essential to reduce mortality and morbidity. Now, the red flags for the severe bleeding. For severe bleeding, including tachycardia, frank blood detected during the nasogastric lavage, and significant and rapid fall in hemoglobin level or value less than 8 gram at presentation. Hematemesis, which is frankly bloody, suggests moderate to severe bleeding. It may suggest ongoing active bleeding. So limited bleeding is suggested by coffee ground vomitus, emesis. If patient has hematemesis and black tarry melena, the source is likely to be proximal to the ligament of Treitz. Now regarding signs and symptoms, severe bleeding is indicated by orthostatic hypotension, confusion, angina, cold clammy palpitation. Less than 15% of blood volume loss will cause mild to moderate hypovolemia and resting tachycardia. If blood volume loss is at least 15%, there will be orthostatic hypovolemia. And supine hypotension occurs with blood volume loss of at least 40%. So this will be estimated fluid in the blood loss in shock. So the class 1 shock includes the blood loss of approximately 77 to 300, blood Blood percentage loss is up to 15%. Pulse rate of less than 100. Blood pressure will be normal. Respiratory rate will be normal or increase. Urine output will be more than 35 ml per hour. Then CNS mental status will be, patient will be slightly anxious. Fluid replacement is given in the form of fluid. Then class 2 patient, that means it includes blood loss of around 750 to 1500 ml. Then blood loss in percentage will be 15 to 30%. Pulse rate will be more than 100 ml. Blood pressure will be normal. Respiratory rate will be decreased. Urine output will be 30 to 40 and the patient will be mildly anxious. The fluid replacement is should be done in the form of hospital. Then the class 3, it includes the blood loss of 1,500 to 2,000 ml. The blood loss in percentage include 30% to 40%. Pulse rate will be more than 120. Blood pressure will be decreased. Respiratory rate will be decreased. Urine output will be around 20 to 30 ml per hour. Then the mental status will be, patient will be anxious and confused. Then the fluid replacement is done in the form of crystalloid and blood. Then in class 4 hypothalamic shock, the blood loss will be more than 2,000. Then the blood loss in percentage will be more than 40%. Pulse rate will be more than 140. Blood pressure will be decreased. Respiratory rate will be decreased. Urine output will be around 14 to 20 ml per hour. Patient will be confused, lethargic, and the fluid replacement will be in the form of crystalloids and blood. Then on presentation, it is essential to get complete blood count, liver function test, renal function test, serum electrolytes, and ABG in population profile. Monitor ECG and cardiac enzymes in elderly or in patients with the coronary artery disease and history of disease. Depending upon the severity of bleeding, measure the hemoglobin every 2 to 8 hours. Keeping in mind that hemoglobin could be faulty low because of hemodilution following fluid resuscitation. In chronic bleeding, the peripheral smear will show microcytic red cells, and in acute bleeding, there will be normocytic red blood cells. The blood urea nitrogen to create ratio and urea to creatinine ratio will be elevated. That will be values will be more than 36 into 1 and more than 100 into 1. In acute BID, due to decreased fluctuation, the bleed is likely to be formed upper GI secretary. The rapid hemoglobin exchange with the acute based disturbance and hyperlactin associated with tissue hypoperfusion can be obtained from arterial blood gas. In case of active bleed, secure two large bore peripheral canals. Secure central venous line when feasible or if peripheral venous access is difficult. Supplemental oxygen can be given by nasal canal. The patient should be kept nearby. If there is worsening in mentation or respiration, consider elective intubation to prevent aspiration. However, chances of developing pneumonia within 48 hours are higher in patients who require intubation and are more likely to have cardiopulmonary complications. Hypotension and active bleed should be treated as per established transfusion guidelines. Vigorous resuscitation with saline and over transfusion should be avoided in patients of varicose bleed as it can precipitate recurrent varicose hemorrhage and worsen precipitate ascites or extravascular fluid collection. NICE guideline recommended giving the fresh frozen plasma for coagulopathy and platelet for thrombocytopenia. Now, risk stratification and triage. Patients who are hemodynamically unstable and actively bleeding. Patient will present with a shock and orthostatic hypotension and who may require inoprop to maintain the hemodynamics. They should be admitted to the intensive care unit for close monitoring with at least ECG, pulse oximetry, automated and invasive blood pressure measurement, and resuscitation should be done aggressively. NICE and SIGN advocate two-step risk assessment strategy, that is varicose assessment and severity assessment. So varicose assessment is based on the presence of confirmed varices if the patient has a risk factor for developing portal hypertension, like proven cirrhosis, chronic liver disease, along with relevant radiological and biochemical findings. The severity assessment is commonly done based on two scores, that is Blatchford score and the Rockall score, which predict the endoscopic and clinical outcome. So endoscopy should be done within 24 hours of admission in patient with high risk scores. Now, these are the severity score that can be used in the upper GI bleed, that is Blatchford score and Rockwell score. So Blatchford score includes the male patient and female patient. So first criteria is hemoglobin. If the hemoglobin is less than 10, then the score is high, that is 6. If urea is between 6.5 to 8, then 2 points are given. If urea is between 8 to 10, then 3 points are given. If urea is between 10 to 25, 4 points. If it is more than 25, 6 points. If systolic blood pressure is between 100 to 109, 1 point is given. If it is less than 100, 2 points. If it is less than 90, 3 points. Then other criteria are pulse more than or equal to 100, 1 point. Melena, presence of melena, 1 point. Presence of syncope, 2 point. Hepatic disease, 2 point. Cardiac failure, 2 point. Then regarding Rockall score, the criteria are age. If less than 60, 0 point. 60 to 79, 1 point. More than 80 is 2 point. Then shock, if pulse is more than 100, 1 point. If systolic blood pressure less than 100, 2 point. Then regarding comorbidity, cardiac and the other major comorbidity, 2 point. Renal failure, liver failure, cancer, 3 point. Then endoscopic diagnosis, normal or maloriviscere, 0 point. Ulcer, erosions, esophagitis, 1 point. Cancer, 2 point. Then regarding endoscopic finding, clean base ulcer, flat pigmented spot, 0 point. Active bleeding, clot, vessel, blood, 2 points. Then the AIM-65 uses the pre-endoscopic criteria, which has a high accuracy for predicting inpatient mortality among patients with upper GI bleeding. And 5 factors are associated with increased inpatient mortality. That is albumin less than 3, then INR ratio greater than 1.5, altered mental status, that is Glasgow score less than 40, disorientation, lethargy, SBP 90 mmHg or less, and age older than 65. Now the management of the blood loss. A dynamic definition which identifies rapid blood transfusion are better suitable for use in day-to-day practice. Hence, acute variceal bleed transfusion of more than 4 PRBC in 1 hour. When ongoing need is forcible or replacement of 50% of total blood volume within 3 hours would be considered as massive blood transfusion. Now, the principles of management of the blood loss. Critical hypoperfusion occurs once the blood has lost 30% of total blood volume and the physiological hemodynamic compensatory mechanism begin to fail. The patient will develop shock if resuscitation is inadequate at this stage. It is important to remember that overzealous resuscitation leads to higher arterial and venous pressure, which may dislodge hemostatic clot, cause more bleeding, and hence can be dangerous. Now, the management of the loss of blood component. Since laboratory turnaround time can be long, coagulation factor can be empirically replaced as per protocol in massive blood losses. The aim is to break the lethal triad of acidosis, hypothermia, coagulopathy that invariably follows massive transfusion, hence improving outcome. Patient without active bleeding who became hemodynamically stable with fluid resuscitation should receive blood transfusion if hemoglobin is less than 9 for high-risk patient and if it is less than 7 in low-risk patient. Transfusion of the platelet may be required if platelet count is less than 50,000. And prothrombin complex concentrate is indicated if INR is more than 2. After transfusion of 4 to 10 units of massive blood transfusion protocol is initiated and it has predefined ratio of RBCs, fresh frozen plasma, cryoprecipitate and platelet for transfusion. These ratios were suggested by pragmatic, randomized, optimal platelet and plasma ratio trial, in which more patients in 1:1:1 group achieved hemostasis and fewer experienced death due to exsanguination by 24 hours. Only two large RCTs studying massive transfusion focus on patients with upper GI hemorrhage. In both studies, the restrictive group had significantly lower 45-day mortality and rebleeding. Patients with chronic liver disease and portal hypertension showed more positive and pronounced effect of restriction. All patients received urgent endoscopy within 6 hours from presentation, which may have impacted outcome, and patient with exsanguinating hemorrhage was excluded. The reason transfusion worsened outcome in some upper GI bleed with portal hypertension also remains unclear. It has been proposed that transfusion increases portal and systemic pressure, therefore promoting further bleeding. These patients also have impairment of coagulation and transfused PRVC, are transiently unable to effectively deliver oxygen to end organ. The stored RBC have stiff membrane, and the blood transfusion in portal hypertension decreases functional capillary density, antigen-mediated immune reaction, and paradoxical dampening of immune response. Now, the complication of massive blood transfusion, an immediate complication seen during massive blood transfusion is inadequate resuscitation, which leads to hypoperfusion that causes lactic acidosis, systemic inflammatory response syndrome, DIC, and multi-organ dysfunction. It is prudent to keep in mind that overzealous resuscitation lead to transfusion-associated circulatory overload and interstitial edema due to increased hydrostatic pressure, which may lead to abdominal compartment syndrome. It also causes dilution coagulopathy and low colloid oncotic pressure, giving rise to interstitial edema. 80 ml of citrate phosphate dextrose aromatic solution present in the blood bath contains approximately 3 grams of citrate in hypoperfusion or hypothermia associated with massive blood loss can decrease this rate of metabolism, leading to citrate toxicity, which causes hypocalcemia, hypomethasemia, and worsens the acidosis. The stored PRBC have high potassium content, hence causing hyperkalemia. Infusion of cold fluids, blood products, and open of gut and abdominal cavities, decrease heat production, all causes hypothermia, which not only reduces citrate metabolism and drug clearance, more importantly, contribute to development of coagulation. Hypomagnesemia occurs as a citrate also bind to magnesium. Now, regarding medical management, patient with acute upper GI bleed should be started empirically on intravenous PPI as it reduces the rate of rebleeding, even though in setting of active upper GI bleed. H2 receptor blocker have not been shown to significantly lower the rate of ulcer repeat. Stabilization of blood clotting occurs with the neutralization of the gastric acid. Then prokinetic agents like erythromycin at a dose of 3 mg per kg intravenously over 20 to 30 minutes, 30 to 90 minutes prior to endoscopy clears the stomach of blood, clot, and food residues, thereby improving visualization and decrease the need for second look endoscopy. Now, the vasoactive medications like somatostatin and its analog, octreotide, terlipressin, reduces the risk of both varicose and non-varicose causes. Prophylactic antibiotic that is ceftriaxone, 1 gram every 24 hours, in those who are already on quinolones like norfloxacin, should be given to patients with cirrhosis who present with acute upper GI bleed. To 20% of patients with cirrhosis who are hospitalized with gastrointestinal bleeding have bacterial infection. Hence, antibiotics should be given prior to endoscopy. So, multiple trials suggest that prophylactic antibiotics reduces the infectious complication and possibly decreases the mortality reducing the risk of recurrent esophageal variceal bleeding in hospitalized patients. Withhold anticoagulant and antiplatelet agent in patients with upper GI bleed whenever possible, and the decision to discontinue medication or administer reversal agent or resume after hemostasis need to be individual. There is no role for tranexamic acid and recombinant factor 7A in treatment of upper GI bleed. Tranexamic acid did not reduce mortality in the trial that included in anti-ulcer drug and endoscopic therapy. Currently, the two large-scale randomized controlled trial of tranexamic acid, that is tau, tau-G, tau-GIG and HALTED trial, should answer whether the tranexamic acid has beneficial effect on serious and uncontrolled upper GI. At least two randomized controlled trial and meta-analysis of those trials failed to demonstrate uh, uh, any clear benefit of recombinant factor 7A in active varietal bleeding. The role of recombinant factor 7A in the management of bleeding awaits further clarification, and it cannot yet be recommended for routine clinical use in patients with variceal bleeding, as most patients will be acidic. Now, regarding endoscopic management, the management of the bleeding lesion varies for varicose and non-varicose source. Endoscopy should be carried out within 24 hours of presentation to determine the cause and initiate early therapeutic intervention. Portal hypertension causes formation of photosystemic shunt and varices, causing variceal bleed. Variceal bleed can be managed endoscopically by sclerotherapy and by band ligation. For sclerotherapy, we can use histoacryl, cyanoacrylate, and thrombin. Mechanical tamponade can be applied with Sengstaken Blackmore tube and the Minnesota tube, or Linton Nicholas tube insertion and self-expanding metal stent for esophagus. Non-varicose upper GI bleed presents in three ways, that is active bleeding, non-bleeding visible vessels, and adherent. Endoscopic therapies for non-varicose upper GI bleed comprise injection therapy, thermal treatment, mechanical adjuncts, and the hemostat. Now, the management after endoscopy, the terlipressin. It is synthetic analog of vasopressin that has longer biological activity, significantly fewer side effects, and NICE recommends the continuing until certainty of hemostasis or up to 5 days at dose of 1 to 2 mg IV every 4 hours. The non-selective beta blocker, within the 6 weeks, the risk of bleeding is 15 to 30%. Recent British Society of Gastroenterology guideline recommended the use of propranolol and nodoline for secondary prevention of bleeding with carvedilol as an option. Now, variceal band ligation, elective repeat endoscopy, 2 to 4 weeks of the schedule after variceal hemorrhage until varices has been eradicated, and transfusion threshold. British Society of Gastroenterology recommended transfusion threshold of 7 to 8 gram in hemodynamically stable patient with varicose. Now, role of interventional radiology. Now, role of interventional radiology, transjugular intrahepatic portosystemic shunt. Portosystemic shunt is created across the liver parenchyma with target to rapidly reduces the portal pressure. TIPS is contraindicated in primary prevention, severe pulmonary hypertension, polycystic liver disease, uncontrolled systemic infection, unrelieved biliary obstruction, then moderate pulmonary hypertension, severe congestive cardiac failure, and advanced cirrhosis. Now, balloon occluded retrograde transvenous obliteration, that is BARD. It is a relatively newer radiological technique used for the management of gastric varices with large gastrosystemic shunt, mainly gastrorenal shunt. The goal is to obliterate varices and their feeding. Now, role of non-selective beta blocker at all sites where portal and systemic circulation communicate, collateral develop as a sequel of portal hypertension. This is accompanied by the splanchnic vasodilation. So, the portal sinusoidal pressure can be determined by the hepatic venous pressure. This can be obtained by passing balloon catheter under radiographic guidance into hepatic vein via femoral and internal vein. Then the hepatic venous pressure gradient predict the risk of developing crisis and the overall prognosis. Now, the prognostic value of hepatic venous portal gradient in patient with CLD. If it is 1 to 5 mmHg, it's normal. If it is 6 to 10 mmHg, then it is a preclinical sinusoidal portal hypertension. If it is a less than 10, then it is a clinically significant portal hypertension. If it is a more than or equal to 12, then that is increased risk of ruptured varices. If it is a more than 16, increased risk of mortality. If more than 20, then treatment failure and increased risk of pre-primary prophylaxis. It is the prevention of development of varices in patients with portal hypertension. In large multi-center placebo-controlled double-blinded trial that enrolled participants with compensated cirrhosis, investigators showed that non-selective beta blocker do not prevent development of varices and are associated with unwanted side effects. So these are the recommended beta blockers for primary prophylaxis against variceal bleeding. So the first one is carvedilol. Then the non-selective beta blockers include nodaluol and propranolol. So carvedilol initial dose is 6.5, the maximum dose is 12.5. Nodaluol, the initial dose is 20 to 40, maximum is 160. Propranolol, initial dose is 20 to 40, maximum dose is 320. Now regarding primary prophylaxis, it is the prevention of variceal hemorrhage in patient with known esophageal varices but no history of variceal hemorrhage. And small esophageal varices, that is non-selective beta blocker, may slow down variceal formation in patient with small esophageal varices that have not bled but have not shown any survival advantage. Since it has potential for side effects that are recommended only for those at high risk of hemorrhage, only varices that have red marks and red spots or those with child turgor with class 3 cirrhosis with medium and large esophageal varices. For patients with medium and large varices, the use of non-selective beta blocker or treatment with endoscopic variceal ligation has been shown to significantly reduce the risk of variceal bleeding. For patients with medium and large varices, the 2016 ASLD prevention guidance recommended primary prophylaxis will be the non-selective beta blocker, carvedilol, and endoscopic variceal ligation. The combination therapy with non-selective beta blocker and endoscopic variceal ligation is not recommended. Then approach to recurrent bleed after it was stopped once. Now secondary prophylaxis. Untreated cirrhotic patient with history of variceal bleed have 60% risk of rebleeding within the 1 year. And the risk of dying with each rebleeding episode is approximately 20%. The modalities used to prevent rebleeding are considered secondary prophylaxis of variceal. Now the pharmacological therapy. Non-selective beta blocker can reduce the risk of rebleeding by 40% and improves overall survival by 20%. Side effect of adding isosorbate mononitrate to non-selective beta blocker are known. Hence, it's recommended to use non-selective beta blocker without isosorbate mononitrate. The recommended non-selective beta blockers are propranolol and noradolol. The data for the carvedilol is insufficient, so it cannot be recommended for secondary prophylaxis of variceal. Now, the endoscopic variceal ligation therapy. Endoscopic variceal ligation therapy is superior to sclerotherapy for secondary prophylaxis. It decreases the rebleeding rate to about 32%. Endoscopic session should be done repeated every 7 to 28 days until varices are eradicated, and then surveillance EGD should be repeated every 3 to 6 months. Now regarding combination therapy of non-selective beta blocker and endoscopic varicella therapy is superior to either modality alone for secondary prophylaxis for varicella bleeding, as it decreases the rebleeding rate to about 40 to uh, 22%. There is no statistical differences in the mortality, but combination therapy is considered and standard first-line therapy for secondary prophylaxis of varicella. Now the next is tips. Placement of the tips has been shown to be superior to endoscopic varicella ligation therapy and pharmacological therapy in reducing risk of renal. TIPS does not improve mortality nor it decreases the incidence of hepatic encephalopathy. If patient had placement of TIPS during acute bleeding, they do not need additional therapy for portal hypertension or varices, but they should be referred for liver transplant. If patient has rebleeding after combination therapy with non-selective beta blocker and endoscopic varicella ligation therapy, placement of TIPS is recommended as recommended rescue therapy. Now, portocaval shunt surgery. A surgical placement of the portocaval shunt is effective in preventing rebleeding. This procedure, however, does not improve survival, increase the risk of developing hepatic encephalopathy, and has been largely replaced by TIPS. Portocaval surgery is primarily reserved for patients with child Turcot class A liver disease. Now the gastric varices, the combination of non-selective beta blocker and endoscopic therapy can be used for secondary varicose hemorrhage prophylaxis or gastroesophageal varices, but for fundal varices, TIPS and BAR2 can be preferred. Now role of mechanical tamponade. The Sengstaken Blackmore tube has three components: gastric balloon, esophageal balloon, and gastric suction. The balloons are for tamponade, while the gastric port is for aspiration of blood from the stomach. Now, the procedure for insertion, most patient will need to be intubated as it is the large tube and very uncomfortable for the procedure patient. However, local anesthesia may be used. Ideally, patient should make to recline with 45-degree head elevation depending on hemodynamics, or alternatively, a left lateral decubitus position can be used to prevent aspiration. The balloons are checked by inflating and submerging underwater for leaks. Then ports are clamped after removing all air. Sometimes nasogastric tube is tied about 4 cm above esophageal balloon and used for aspiration of blood from the esophagus. The tube is lubricated and then it is passed in the stomach up to 15 cm. First gastric balloon is inflated with 100 ml increment and then pressure is measured. If the pressure is above 15 mmHg, the balloon may be in the esophagus and it need to be deflated. The tube then advances further till it correctly positions. Then gastric balloon is inflated with 450 to 500 ml of air and the ports are clamped. Proper placement can be confirmed by irrigating gastric aspiration port with water while ausculting over stomach. The tube is pulled back gently under resistance is felt. The tube is put on the traction device using tube. The gastric port is aspirated to check the bleeding. Bleeding continues. The esophageal balloon is inflated to lowest pressure needed to stop bleeding. Then port is kept. A periodic watch is kept on the balloon pressure. If bleeding is still continuing, the traction is increased further to maximum 1.1 kg. Once bleeding is controlled, esophageal balloon pressure is decreased by 5 mmHg every 3 hours to 25 mmHg. This pressure is maintained for 12 to 24 hours. The esophageal balloon should be deflated for 5 minutes every 6 hours to help prevent esophageal necrosis. If bleeding recurs, the gastric balloon, if necessary, Esophageal balloon may be re-inflated for additional 24 hours. Sandstaker Blackmore tube and Minnesota tube are devices that provide balloon temper and temporarily be used in uncontrollable hemorrhage. It is 85 centimeter long, comes in various sizes from 14 French to 21 French. Air is filled with increment of 100 ml up to 250 to 300 ml for Sandstaker Blackmore tube and 400 ml for Minnesota tube after inserting 50 centimeters. Check pressure at each step. Withdraw till resistance is felt. Then appropriate esophageal pressure at 25 to 30 mmHg up to maximum of 40 Hg. Traction is usually 1 to 2 kg, which is equivalent to 500 ml of the fluid. Always get chest X-ray with upper abdomen done. If bleeding has stopped, then it should be depleted by 10 mmHg every 2 hours. Tracheal intubation will then be needed to avoid esophageal rupture and ensure proper device placement prior to inhalation. To avoid necrosis, it should be removed with 24 to 36 hours, pressure kept at 50. Now, the contraindication for the use of Sandstaker Blackmore tube is unprotected airway, esophageal rupture, esophageal stricture, uncertainty regarding source of bleed, and well-controlled variceal bleed. Now, the role of TAPE. The coagulation abnormalities seen in patients with the liver disease include INR, increased INR, APTT, prolonged PT, thrombocytopenia, and elevated D. Since they only reflect the change in procoagulant activity, these tests are very poor at predicting risk of bleeding in individuals with the liver disease. Therefore, viscoelastic testing such as TAPE and ROTEM are being studied in patients with liver disease and used during liver transplantation. TAG is non-invasive test that quantitatively measures the ability of whole blood to form clot. The principle for this is in vitro test to detect and quantify dynamic changes of viscoelastic properties of blood sample during clotting under low shear stress. This waveform is the representation of normal tape tracing. So the first is R time, that is reaction time. That is time in minute elapsed from start of the test until clot moves between enough to produce 2 mm of amplitude on tracing and is defined as reaction. This R reflects the activity of the coagulation cascade, and the coagulation factor deficiency produces prolonged R. Hypercoagulability yields shorter. Normal values for R depend upon the type of the clotting activator used. Prolongation of R time reflects the quantitative and the qualitative deficiency of coagulation factor that may be corrected by fresh frozen plasma, transfusion, prothrombin complex, and anticoagulant reversal. Then alpha angle is the measure in degrees of speed of clot formation that it reflects the conversion of fibrinogen to fibrin. It is defined as angle between horizontal axis of tracing and the tangent of the tracing at 20 mm amplitude. The decreased angle indicates lower rate of clot strengthening as seen in low fibrinogen. Normal values are between 44 to 55. So depressed alpha angle could be treated with cryopreserve. Now the coagulation time. The coagulation time, that is K time, is measured in minute from the end of R when tracing amplitude reaches the 20 mm. Like alpha angle, the K is determined by the rate at which the clot formation happens. So the prolongation of the K time and the decreased alpha angle suggests the deficiency of fibrinogen, which should be corrected by cryopreserve. The low MA indicates the quantitative and the functional deficiency of platelet and could be corrected by platelet concentrate transfusion. Finally, the increased lysis value implies the activated fibrinolysis that may be treated by fibrinolysis. The opposite changes in the take parameter suggest the prothrombin state. This interpretative approach represents the convenient but rather simplified view on disturbance of blood coagulation. It is important to remember that due to complex nature of hemostasis, the take parameters are interrelated. So these are the important take parameters. So first diagram is the normal. Then the second is the representative of anticoagulant hemophilia, that is factor deficiency, in which R and Ks are prolonged. and mean amplitude and angle is decreased. Then the third is representative of take on the uh, take in patient with platelet blocker, that is thrombocytopenia and thrombocytopathy. Then fourth one is representative of fibrinolysis. Fifth one is hypercoagulable state. Then next is suggestive of DIC, which is first one is hypercoagulable, and the next is hypocoagulable state. Thank you, guys.